Chapter 22 in MedSurg TIMBY, Introduction to Cardiovascular System. The function of the cardiovascular system is to supply body cells and tissues with oxygen-rich blood and eliminate carbon dioxide and cellular waste. Damage to and disease within the cardiovascular system greatly jeopardizes a person's health. In fact, heart disease is the leading cause of death for adults in the U.S. Many advanced treatments have been and are being created to reduce deaths from heart disease. Human heart transplantation and the temporary use of the total artificial heart as a bridge to transplant or permanent heart replacement are realities. The primary focus remains on preserving the natural heart by preventing heart disease. Anatomy and physiology. The cardiovascular system consists of the heart, the major blood vessels that empty into or exit directly from the heart, and a vast network of smaller peripheral blood vessels. The heart itself is about the size of a person's fist. It lies below and slightly to the left of the midline of the sternum and the mediastinum, a portion of the thoracic cavity that also contains the trachea and major blood vessels. The upper portion of the heart is the base, and the tip is the apex. And as you can see from the picture in your book on page 363, you have the aortic arch, which is the semicircular huge aorta coming from the left ventricle, the blood supply. Then you have the pulmonary artery, which is venous blood delivered to the lungs from the right ventricle. Then you have the pulmonary veins, which are oxygen-rich coming back from the veins into the heart, into the left atrium. And then you have the aortic valve, which is between the left ventricle and the left atrium. Then you have the the aortic valve is the valve between the left ventricle and going out to the body. And the mitral valve is between the left atria and left ventricle. Then you have chordae tendineae, which are muscles at the about the middle of the heart there. Then you have the left ventricle, papillary muscles, interventricular septum, visceral pericardium and pericardial spaces, pericardial, parietal pericardium, and myocardium. You also have epicardium and endocardium. Then you have, going backwards, the descending aorta, which is blood-rich supply going to the body. You have the superior vena cava, where the veins empty into from the upper body. The right pulmonary artery, which is venous blood that's going to the lungs. Then you have the pulmonic valve, which is between the right ventricle and the pulmonic artery. Then you have the interatrial septum, dividing the two atria. Then you have pulmonary veins, again oxygen-rich, going to the heart and elsewhere. Right atrium is where the superior vena cava, the superior vena cava and the inferior vena cava empty into the right atrium. Then you have the tricuspid valve, which is between the the right atrium and the right ventricle. Then you have the right ventricle, the inferior vena cava coming in from the bottom, as you can see, and it comes up and empties into the right atrium. And then you have the papillary muscles again, which help control the valve. Heart chambers. The heart is a four-chambered muscular pump. The upper chambers, the right and left atria, singular as atrium, are the receiving chambers for blood. The lower chambers, the right and left ventricles, are the heart's major pumping chambers. A thick septum or wall separates the right side of the heart from the left side. The right atrium receives deoxygenated blood from the venous system, and the right ventricle pumps that blood to the lungs to be oxygenated. The left atrium receives oxygenated blood from the lungs, and the left ventricle pumps that blood to all the cells and tissues of the body. Therefore, the heart is a double pump The right side facilitates pulmonary circulation, and the left side is responsible for systemic circulation. Cardiac tissue layers. 3 distinct layers of tissue make up the heart wall. The outer layer is the epicardium, which is composed of fibrous and loose connective tissue. The middle layer is the myocardium, consists of muscle tissue, and is the force behind the heart's pumping action. The inner layer, the endocardium, is composed of thin, smooth layer of endothelial cells. Folds of endocardium form the heart valves. The endocardium is in direct contact with the blood that passes through the heart. The pericardium is a sac-like structure that surrounds and supports the heart. 2 membranous layers from the pericardium. The outer layer, tougher layer, is the parietal pericardium. The inner serous layer is called the visceral pericardium, also called the epicardium, which adheres to the heart itself. The density of the parietal pericardium safeguards the heart from invasion by infectious microorganisms. Serous fluid fills the pericardial space between the 2 layers, lubricating the heart and reducing friction with each heartbeat. Heart valves. The valves of the heart are membranous structures that ensure that blood passes through the heart in a one-way forward direction. In a normal heart, the valves do not allow blood to backflow or regurgitate into the chamber from which it has come. The 2 atrioventricular AV valves separate the atria from the ventricles. They prevent blood from returning to the atria when the ventricles contract. These valves are cusped or leaf-like. The valve between the right atrium and the right ventricle is the tricuspid valve. The word tricuspid signifies that the valve has 3 cusps. The valve between the left atrium and the left ventricle is the bicuspid or 2-cusped valve, also known as the mitral valve. Attached to the tricuspid and mitral valves are cord-like structures known as chordae tendineae, which in turn attach to papillary muscles, 2 major muscular projections from the ventricles. When the ventricles contract, the papillary muscles also contract, applying tension to the atrioventricular valves. The contraction of the papillary muscles and firm support of the chordae tendineae prevent eversion of the valves and regurgitation of blood back into the atria. The other 2 valves, called the semilunar valves because they resemble portions of the moon, prevent blood from flowing back into the ventricles after the heart contracts. The valves are named for the blood vessel into which the blood is deposited. The valve between the right ventricle and pulmonary artery is the pulmonic or pulmonary valve. The valve between the left ventricle and aorta is the aortic valve. Contraction of the ventricles forces blood into the pulmonary artery and aorta. Relaxation follows, and the fall in pressure in the ventricles causes the pulmonic and aortic valves to close, preventing backflow into the ventricles. Question. The major functions of the cardiovascular system is to perform all of the following except supply of oxygen-rich blood to tissues, elimination of carbon dioxide, transportation of nutrients, and exchange of oxygen and carbon dioxide. The answer is exchange of oxygen and carbon dioxide. The rationale is the exchange of oxygen and carbon dioxide between the body and the outside environment is a function of the lungs known as ventilation and is not a primary function of the heart. Arteries and veins. Arteries carry oxygenated blood from the heart, and veins return deoxygenated blood to the heart. The smallest arteries are called arterioles, and the smallest veins are called venules. Arteries and arterioles are elastic and dilate or constrict to accommodate changes in blood flow. Veins have thinner walls than arteries because venous pressure is lower than arterial pressure. Despite being thinner, veins have large diameters than corresponding arteries. Arterioles branch into capillaries, which are microscopic vessels that form a connecting network between arterioles and venules. Capillaries are one cell layer thick and in direct contact with the cells of all tissues. This complex circulatory network delivers oxygen and metabolic substances to the cells. After this exchange, the venules and veins transport blood back to the heart. Heart contraction moves blood from the heart into arteries and arterioles. Skeletal muscle contraction compresses veins and propels blood back to the heart. Closure of successive sets of valves and veins keep the blood from pooling under the influence of gravity. Cardiopulmonary circulation. The largest veins, the inferior vena cava and superior vena cava, bring venous, deoxygenated blood from all areas of the body into the right atrium. The right atrium fills with blood and the tricuspid valve opens. Blood then travels into the right ventricle and is pumped into the pulmonary artery, the only artery in an adult that carries deoxygenated blood. The pulmonary artery branches to deliver venous blood to the right and left lungs. The lungs exchange the oxygen in inspired air for the CO2 in the venous blood. The CO2 is transferred into the alveoli and exhaled. The pulmonary veins then bring the oxygenated blood into the left atrium. The oxygenated blood flows out of the left atrium through the bicuspid or mitral valve and into the left ventricle. The left ventricle then pumps the blood through the aorta to all the body's cells and tissues. Blood supply to the heart. The left and right coronary arteries supply oxygenated blood to cardiac muscle. The openings to the coronary arteries are called the coronary ostia, singular is ostium, lie at the base of the aorta. When the left ventricle is filling with blood, the coronary ostia dilate and fill with blood. Thus, the myocardium is the first tissue of the body to receive oxygen-rich blood with each heartbeat. After having distributed oxygenated blood to the myocardial cells, the coronary veins carry away the CO2 produced by cellular metabolism. The coronary veins empty into the coronary sinus in the right atrium. The blood then mixes with blood from the inferior and superior vena cava and is recirculated to the lungs. Cardiac cycle. The term cardiac cycle refers to the sequence of electrical and mechanical events in the atria and ventricles that result in a heartbeat. First, the atria fill and then contract simultaneously to fill the resting, relaxed ventricles. This is called diastole, with blood. When the pressure from accumulating blood increases in the ventricles, they contract, which is systole, and after a brief pause, the cycle begins again. The contraction of the left ventricle can be felt as a wave-like impulse, the pulse, in peripheral arteries. The pause between pulsations is ventricular diastole. The conduction system of the heart. The conduction system, which plays a role in the cardiac cycle, sustains the electrical activity of the heart. It consists of the SA node, sinoatrial, the AV node, atrioventricular, and bundle of His, HIS, bundle branches, and Purkinje fibers. The SA node is an area of nerve tissue located in the posterior wall of the right atrium. The SA node is called the pacemaker of the heart because it initiates the electrical impulses. Normally, it produces between 60 and 100 impulses per minute. The average is approximately 72 impulses per minute. Other areas in the conduction pathway may initiate an electrical pulse if the SA node malfunctions, but they do so at rates slower than the SA node. In the normal sequence of events, The cardiac impulse starts in the SA node. It spreads through the atria over intranodal and interatrial pathways. The waves of stimulation through the heart resemble the rings that a pebble makes when dropped into a pond. Once the cells in the atria are excited, they contract in unison. When the impulse reaches the atrioventricular node or AV node, it is delayed a few hundredths of a second. While the ventricles fill with blood, the impulse travels from the AV node to the bundle of His, to the right and left bundle branches, and eventually to the Purkinje fibers. Then both ventricles contract. During diastole, while the myocardial cells are at rest, and before an impulse is generated, the cells are in a polarized state called polarization. Positive ions predominate outside myocardial cell membranes, negative ions predominate inside. When an electrical impulse is initiated, it spreads from cell membrane to cell membrane, causing a transfer of ions. The positive ions move inside the myocardial cell membranes, and the negative ions move outside. This process, which corresponds with cardiac muscle contraction, is called depolarization. It occurs first in the atria and then in the ventricles. Once depolarization has occurred, the ions realign themselves in their original position and wait for another electrical impulse. This process is called repolarization. Another normal cardiac impulse cannot be carried out until the ions are again in polarized alignment. The time during which the cells are resistant to electrical stimulation is called the refractory period. Depolarization and repolarization produce electrical changes. Because body tissues conduct current easily, this electrical activity can be detected by electrodes placed on the external surfaces of the body. The detection of the energy is recorded by a machine known as the electrocardiogram, known as the ECG or EKG. Conduction system of the heart. Review. Polarization is during diastole when the myocardial cells are at rest. Depolarization is when the cardiac muscle contracts. Repolarization is when polarized alignment occurs, another electrical impulse gets ready. Refractory period, cells resist electrical stimulation, and an EKG or ECG shows detection of electrical activity in the heart. Regulation of heart rate. Heart rate fluctuates according to stimulation from the autonomic nervous system, baroreceptors, and chemoreceptors. The autonomic nervous system affects heart rate through sympathetic and parasympathetic nervous system innervation. When released by sympathetic nerve fibers, adrenergic neurotransmitters such as norepinephrine and epinephrine excite the SA node in the conduction system, increasing heart rate. These same neurotransmitters also stimulate beta adrenergic receptors in the atria and ventricles, increasing the force of myocardial contraction. Conversely, the heart slows when parasympathetic nerve fibers from the cardiac branches of the vagus nerve release the cholinergic neurotransmitter acetylcholine. Parasympathetic neurostimulation, however, usually does not affect the force of contraction. Responses to baroreceptors, pressure-sensitive nerve endings in the walls of the atria and major blood vessels, such as the vena cava, the arch of the aorta, and carotid arteries, also affect the heart rate. The main function of baroreceptors is to sense the pressure from blood as it stretches vascular tissues containing the baroreceptors. If blood pressure decreases in the area of the baroreceptors, such as when a person rises quickly from a lying or standing position, the baroreceptors send impulses to the brainstem to increase the heart rate. An almost immediate reflexive response of accelerated heart contractions follow. The heart rate increases to compensate for the drop in blood pressure. When the blood pressure is stabilized, the heart rate returns to within a normal range. Chemoreceptors are structures that are sensitive to the pH and CO2 and oxygen levels of blood are located in the carotid bodies, aortic bodies, and medulla of the brain. They regulate sympathetic stimulation or inhibition. A fall in pH, a rise in CO2, and a decrease in oxygen levels in the blood result in increased heart contraction. The heart rate returns to a more normal, usual parameter when pH and CO2 levels become normalized. On page 366, figure 22.6 are some pictures of the baroreceptors and chemoreceptors and where they act. Cardiac output is the amount of blood pumped out of the left ventricle each minute. In a healthy adult, cardiac output ranges from 4 to 8 liters per minute. The average is approximately 5 liters per minute. Volume varies according to body size. The heart adjusts cardiac output to the body's changing needs. During active exercise, athletes may have a cardiac output that is 5 to 7 times the normal amount. Cardiac output can be increased in 2 ways, by increasing the heart rate and by increasing the stroke volume. Stroke volume is the amount of blood pumped per contraction of the heart. The stroke volume averages about 65 to 70 mLs. The following formula is used to calculate cardiac output. Cardiac output equals heart rate times stroke volume. Note: gerontologic considerations. Changes in cardiovascular structure and function in older adults are related to genetic risk factors, lifestyle environmental influences such as smoking, inadequate nutrition, lack of exercise, and changes from the aging process itself. Include age, lifestyle, environmental risk factors, and family history during an assessment. Early identification of risk factors facilitates early preventative efforts before actual damage occurs. Teaching of potential benefits can increase motivation for early and midlife health behaviors. Sarcopenia refers to changes in the composition of muscle tissue that can occur in aging as the result of deconditioning. Muscle fiber reduction and replacement with fatty tissue decreases the strength of muscle contraction and thus can decrease cardiac output. Sarcopenic changes can be reduced to maintain or improve cardiac function through exercise that causes the heart muscle to work harder, such as brisk walking, swimming, dancing, etc., if not contraindicated. The aging heart requires more time to return to baseline levels after stress. This inability to handle stress results from decreased cardiac output and contractile strength, and delayed conduction in the heart. Assessment of the cardiovascular system. History. The initial assessment includes the client's or family member's description of the symptoms the client experienced before and during admission. The history also includes the client's past medical history and family medical history. The family medical history is important because many cardiac disorders have a familial or genetic predisposition. If close blood relatives are no longer living, it is important to ask about the cause of death, age at death, and relationship to the client. The nurse asks the client to identify prescription and non-prescription drugs and herbal substances and that she or he is taking. Adverse effects or drug interactions can contribute to cardiac symptoms. Use of illicit drugs such as cocaine and methamphetamine is also significant to the cardiac history. Drug and food allergies are noted because future diagnostic procedures may involve the administration of drugs or substances such as radiopaque dyes. When assessing the medication history, be sure to ask specifically about non-prescription medications and herbal or nutritional supplements. Clients may not think of these items as medications, yet they can also impact blood pressure, pulse, or cardiac function. Physical exam. General appearance. An appraisal of the client's general appearance may suggest problems that require further exploration. The client's nonverbal behavior and body position may indicate that he or she is anxious, depressed, in pain, or uncomfortable. Pain. Poor circulation, a common problem in clients with cardiovascular disorders, causes ischemia, which is reduced blood supply, to body organs. A classical sign of ischemia is pain, which results from a lack of oxygen in the tissue. Chest pain is a manifestation of ischemia to the heart muscle. Leg pain, especially with activity, can indicate inadequate oxygenation to leg muscles. When pain is present, the nurse evaluates it carefully. Obtaining as much information as possible is essential. Prompt management of pain is extremely important. Vital signs. Temperature. Fever is characteristic in some types of heart disease. It can accompany the inflammatory response when myocardial cells are damaged after an acute MI or heart attack, or infections such as rheumatic fever and bacterial endocarditis. Pulse. When taking a client's pulse, the nurse notes its rate, rhythm, and quality. Pulse rhythm is the pattern of the pulsations and the pauses between them. A normal pulse is felt regularly with a similar length of pause. The pulse quality refers to its palpated volume. Pulse volume is described as feeling full, weak, or thready, meaning barely palpable. The nurse also determines any pulse deficit by counting the heart rate through auscultation at the apex of the heart, while a second nurse simultaneously palpates and counts the radial pulse for a full minute. The difference, if any, is called the pulse deficit. Respiratory rate. The nurse counts the respiratory rate for 60 seconds. He or she observes the character of the respirations, noting whether the client's breathing is effortless or labored, which is called dyspneic, deep or shallow, noisy or quiet. The use of accessory muscles, such as neck or abdominal muscles, during respiration is an indication that the client is having difficulty breathing. Blood pressure. Cardiac disorders often are associated with changes in blood pressure. If the client is not acutely ill, the nurse takes the blood pressure with the client in the lying, sitting, and standing positions. This is called orthostatic vital signs. These baseline determinations are necessary to monitor the effects of cardiovascular disease and drugs that can alter the blood pressure during position changes. To ensure an accurate assessment, the nurse selects the cuff width most appropriate for the diameter of the client's arm. The nurse takes the blood pressure in both arms on admission and at least once a day after, making sure to report a marked difference in pressure between the left and right arms. When charting, the nurse identifies the arm used to measure the blood pressure and the client's position at the time it was measured. The nurse questions the client about dizziness or lightheadedness when changing positions, such as rising from a sitting or lying position. These symptoms may indicate postural or orthostatic hypotension. Assessment of the cardiovascular system. Cardiac rhythm. The electrical activity that produces the heart rhythm can be observed continuously with bedside cardiac monitoring. Electrodes are attached to the chest and connected to a machine that displays the cardiac rhythm on an oscilloscope. The components of an EKG are discussed later in this chapter. A paper strip of the cardiac rhythm can be printed and attached to the client's record. A cardiac monitor reveals the heart's electrical but not its mechanical activity. The healthcare provider must palpate a peripheral pulse or auscultate the apical heart rate to obtain this information. Comparing the heart rate and rhythm with the information displayed on the monitor is important because the EKG pattern may appear normal in some clients even when mechanical function is abnormal. Cardiac telemetry sends EKG information over radio waves to a monitor that is distant from the client. Paramedics use telemetry to communicate information to healthcare providers in the hospital emergency department. Telemetry also may be used when the client's condition is stable enough to allow transfer from a critical care unit, but still requires continuous monitoring. When telemetry is used, the electrodes are attached to a battery pack, which is secured inside a pocket on the client's hospital gown or clothing. Age-related changes in the conductive system include a decrease in the number of pacemaker cells and changes in their shape. An increase in fat deposits, collagen, and elastic fibers in the SA node leads to a higher risk for cardiac arrhythmias. Abnormal rhythms are difficult to treat in the older adult because organs can be further compromised by the lack of adequate blood supply if other chronic conditions exist. Heart sounds. Normal heart sounds. Auscultation of the heart requires familiarization with normal and abnormal heart sounds. The first heart sound lub, refers to as S1, is the closing of the mitral and tricuspid valves. S1 is heard loudest over the apex of the heart and occurs nearly simultaneously with the palpated pulse. The second heart sound, dub, refers to as S2, is the closing of the aortic and pulmonic valves. S2 is heard loudest with the stethoscope in the aortic area, which is at the second intercostal space to the right of the sternum. Abnormal heart sounds. All other heart sounds are abnormal and take considerable practice to recognize. A sound that follows S1 and S2 is called an S3 sound, or a ventricular gallop. When these three sounds are heard together, some say the cadence sounds like Kentucky or lub-dub-dee. An S3, although normal in children, often is an indication of heart failure in an adult. An extra sound just before S1 is an S4 heart sound or atrial gallop. Some say this sound resembles the word Tennessee or lub-dub-dub. An S4 sound often is associated with hypertensive heart disease. In addition to heart sounds, auscultation may reveal other abnormal sounds, such as murmurs and clicks caused by turbulent blood flow through diseased heart valves. A friction rub may cause a rough, grating, or scratchy sound that is indicative of pericarditis, which is inflammation of the pericardium. Peripheral pulses. The nurse palpates the radial arteries and other peripheral arteries during the physical assessment. He or she records the presence or absence of these pulses and their strength. So you have the carotid, the temporal, the brachial, the radial, the ulnar, the femoral, the popliteal, the posterior tibialis, and the dorsalis pedis. And you can see these on page 369 in TIMBY MedSurg, figure 22.8. Areas assessed when evaluating heart function. Heart sounds can be auscultated in the aortic area, pulmonic area, Erb's point, tricuspid area, and apical area. And there's a nice picture of this on page 369 in TIMBY MedSurg, figure 22.7. Question. A function of the tricuspid valve is, it allows blood to flow out of the left ventricle into the aorta, or it allows blood to flow from the right atrium into the right ventricle, or it allows blood to flow out of the right ventricle into the pulmonary artery, or it allows blood to flow from the left atrium to the left ventricle. Your answer should be B, it allows blood to flow from the right atrium into the right ventricle. The rationale is the function of the tricuspid valve is to prevent blood from returning to the atria when the ventricles contract. The tricuspid valve is between the right atrium and right ventricle. Assessment of the cardiovascular system. In addition to peripheral pulses, skin assessment. Many clients with cardiac disorders exhibit changes in skin color, such as cyanosis, which is blue, or pallor, which is pale. A good light is necessary when assessing skin color. Cyanosis can be detected by carefully noting color changes in the oral mucous membranes, as well as in the lips, earlobes, skin, and nail beds. In light skin clients, extreme pallor is easy to detect because the skin appears almost bloodless. In dark skin clients, a grayish cast to the skin usually indicates pallor. The nurse inspects the arms and legs for variations in skin color and temperature and compares his or her bilateral findings with other areas of the body. Sparse hair growth on the legs and thick toenails can indicate poor circulation. The nurse also notes any varicosities, which is enlargement of veins, that are observed in the lower extremities. Peripheral edema. Edema occurs when blood is not pumped sufficiently or efficiently, or plasma protein levels are inadequate to maintain osmotic pressure. When blood has nowhere else to go, the extra fluid enters the tissues. Particular areas for examination are the dependent parts of the body, such as the feet and ankles. Other areas prone to edema are the fingers, hands, and over the sacrum. To assess for edema, the examiner gently presses his or her fingers into the skin and then quickly releases. If the mark of the fingers remains, the effect is termed pitting edema. Edema is evaluated on a scale of 1+ to 4+, depending on the depth of the pit and the amount of time it takes the pit to disappear. The higher the number, the more pronounced is the edema. Weight. Weight gain can indicate edema. A rapid gain in weight often means that edema is increasing. Weight loss often reflects the loss of excess fluid from the tissues and is used to evaluate the effectiveness of drug therapy, especially diuretics. If weight is recorded daily, the nurse weighs the client at the same time with the same amount of clothing using the same scale each day. The weight is recorded as accurately as possible. Jugular veins. If the right side of the heart fails to pump efficiently, blood becomes congested in the neck veins. With the client sitting at a 45-degree angle, the client turns his or her head to the right or left so the nurse can inspect the external jugular vein. Distension of this vein usually indicates increased fluid volume and pressure in the right side of the heart. Lung sounds. If the left side of the heart fails to pump efficiently, blood backs up into the pulmonary veins and lung tissue. The nurse auscultates the lungs for abnormal and normal breath sounds. With left-sided heart failure, auscultation reveals a crackling sound and possibly wheezes and gurgles. Wet lung sounds are accompanied by dyspnea and an effort to sit up to breathe. If uncorrected, left-sided heart failure is followed by a right-sided heart failure because the circulatory system is a continuous loop. Sputum. Clients with cardiac disease may have a productive or non-productive cough. The nurse notes the type and frequency of the cough and the amount and presence of and appearance of the sputum. These findings can be important in diagnosing heart failure or other pulmonary complications. Mental status. Some clients with cardiac disorders may be alert and oriented, and others may be alert, confused, or disoriented. Confusion or disorientation can result from a disease in the oxygen supply to the brain called cerebral ischemia as a result of poor circulation. Chest pains and impaired breathing can create anxiety. The nurse reports extremes of emotion or disturbances in thought processes to the physician because such effects could interfere with the client's safety, diagnostic testing, and prescribed therapy. Question. A nurse is examining a client with a history of cardiac disease. An assessment finding that indicates cardiac dysfunction includes which of the following? Presence of pedal edema, irregular heart rhythm, clubbing of fingers, or all of the above? Your answer should be all of the above. The rationale being abnormal vital signs include heart rate, abnormal heart sounds, and general appearance changes include skin, temperature, distended neck veins, clubbing of fingers, and presence of edema are all assessment findings associated with cardiovascular disease. Diagnostic tests. Lab tests. Various general lab tests are used in the diagnosis of heart disease and in monitoring the client's progress. Lab tests may be performed daily or every few days. They may be used to monitor the results of therapy. Blood chemistry such as fasting blood glucose and serum electrolyte, cholesterol, and triglyceride levels may be used as part of the diagnostic process. Analysis of serum enzymes and isoenzymes may also be ordered. Serum cholesterol and lipid tests and isoenzyme analyses are discussed in more detail in another chapter. When tissues and cells break down, are damaged, or die, large quantities of certain enzymes are released into the bloodstream. Enzymes can therefore be elevated in response to cardiac or other organ damage. Radiography and radionuclide studies. Chest X-rays and fluoroscopy determine the size and position of the heart and condition of the lungs. These studies are also used to guide the insertion and confirm the placement of cardiac catheters, internal pacemaker wires, and internal cardiac defibrillators. CT scanning and magnetic resonance imaging are used to determine heart size and detect lung involvement. Radionuclides are radioactive chemical elements that are injected into and travel through the bloodstream. Their use sometimes is referred to as nuclear cardiology. The radionuclide technetim 99M is used to detect areas of myocardial damage. The radionuclide thallium-201 is used to diagnose ischemic heart disease during a stress test. MRI's magnetic resonance imaging is a diagnostic tool used for drug-induced stress testing. Drugs may be used to stress the heart for clients with sedentary lifestyles or those with a physical disability such as severe arthritis that interferes with exercise testing. Drugs such as adenosine, adenocard, dipridiamole, which is persantine, or dobutamine, Dobutrex, may be administered singularly or in combination by the IV route. The drugs dilate the coronary arteries, similar to the vasodilation that occurs when a person exercises to increase the heart's muscle blood supply. When thallium, a radionuclide, is injected a few minutes later, a scan of the heart can detect compromised blood flow, which indicates coronary artery disease or evidence of a well-perfused heart muscle. Often medications are held for 24 hours before procedures. Confer with the physician regarding medications for chronic conditions. This is especially important for those who take heart, hypertension, or diabetes medications. Cardiac catheterization. Cardiac cath is a diagnostic test performed in an operative setting. It can be done for a variety of purposes. In this procedure, a long, flexible catheter is inserted from a peripheral blood vessel in the groin, arm, or neck into one of the great vessels, such as the inferior or superior vena cava, which is attached to the heart, and then into the heart. Cardiac catheterization may be carried out on the left side of the heart by way of an artery or on the right side by way of a vein. Before the procedure, the client needs to consult the physician about which prescribed medications to take or omit the day of the cardiac catheterization. Food and fluids usually are withheld. However, if the test is late in the day, a light food may be permitted. Allergies must be identified. Those of primary concern before a cardiac cath are iodine, shellfish, radiographic dye, and latex. IV fluids are administered before the test to maintain hydration and to administer any necessary meds. A sedative may be administered before the test. For a diagnostic cardiac cath, conscious sedation using midazolam, which is called Versed, may be used. Conscious sedation allows the client to be sleepy and comfortable but sufficiently awake to respond to questions and positional changes. A local anesthetic is administered at the site where the catheter is inserted. General anesthesia is reserved for a cardiac cath that will involve cardiac surgery. After the test, the catheter is removed and the site is covered with a pressure dressing to control bleeding. The usual length of stay following a cardiac catheterization is at least 5 to 9 hours or overnight. After the test, the nurse monitors blood pressure and pulse frequently to detect complications. He or she also checks the dressing over the insertion site frequently for signs of bleeding. The nurse palpates the pulse in various locations and checks the color and temperature in the extremity to confirm that blood is circulating well. Instructions for the client and family include the following. Keep the extremity straight for several hours and avoid movement. Report any warm, wet feeling that may indicate oozing blood, numbness, tingling, or sharp pain in the extremity. Drink a large volume of fluid to relieve thirst and promote the excretion of the dye. Follow discharge instructions for home care. Discharge instructions for clients having cardiac cath. The nurse instructs the client as follows. Rest for the next 3 days and avoid heavy lifting, strenuous activity, or sports. Do not drive or climb stairs for the next 24 hours. Do not take a tub bath until the puncture site is healed. Change the bandage in 24 hours. Continue changing the bandage until a crust or scab forms over the puncture site. You may experience some soreness at the puncture site. However, if it becomes worse, notify your physician. If pain or swelling of the puncture site occurs, notify your physician. If the puncture site begins to bleed, hold pressure over the site and call 911 or another emergency service number. Coronary arteriography. The most common use of a left-sided cardiac cath is to determine the degree of blockage of the coronary arteries by performing arteriography while the catheter is in place. An arteriography is a diagnostic procedure that involves instilling contrast medium into an artery. In this case, it is instilled into the catheter and deposited into each coronary artery. Occlusive heart disease is indicated if one or more coronary arteries appear narrow or do not fill. Clients with coronary artery disease who are considered candidates for invasive treatment procedures must undergo cardiac cath and coronary arteriography. After removal of the catheter, the nurse inspects the insertion site for bleeding, tenderness, hematoma formation, which is a bruise, and inflammation. The client remains on bed rest for the rest of the day. He or she must avoid flexion or bending of the arm or leg used for catheter insertion. Vascular assessments distal to the insertion site can continue at frequent intervals. In other words, check the pulses that are at the feet or at the hands. Absent distal peripheral pulses, cool toes, and pale or cyanotic arms and legs indicate arterial occlusion, usually from a blood clot. These signs, as well as a rapid or irregular pulse rate, indicate a medical emergency that the nurse must report to the physician immediately. Peripheral arteriography is used to diagnose occlusive arterial disease in smaller arteries. Contrast medium is injected into an artery and radiographic films are taken. After the procedure, the chance for bleeding is greater than after a venipuncture. Therefore, a pressure dressing is applied and client activity is restricted for about 12 hours. The nurse observes the client for bleeding and cardiac arrhythmias and assesses the adequacy of peripheral circulation by frequently checking the peripheral pulses. Angiocardiography. A radio-opaque contrast medium is injected into a vein and its course through the heart is recorded by a series of radiographic pictures taken in rapid succession. The pictures reveal the size and shape of the heart chambers and greater vessels and the sequence and time of their filling with dye. Angiocardiography is used particularly to diagnose congenital abnormalities of the heart and great vessels. It usually is performed when a simpler diagnostic measure fails to provide the necessary information. The client fasts for at least 3 hours before the test. A sedative and an antihistamine medication usually are administered before the client is taken to the radiography department. Aortography detects aortic abnormalities such as aneurysms, which is an abnormal dilation of a blood vessel wall, and arterial occlusions. When aortography is performed, contrast medium is injected and radiographic films are taken of the abdominal aorta and major arteries in the legs. Distribution of the contrast medium also may be observed as it circulates to other vessels such as the renal arteries in the kidneys. The older adult who has renal impairment or is chronically dehydrated is at increased risk for complications during and after diagnostic studies requiring the use of a contrast medium because the iodine contrast dye is kidney toxic and interventions to hydrate should be considered prior to the test. This is the end of the slideshow.